All right. Happy Friday, everyone. It is so good to see you all. I am looking outside a window of 30 inches of snow. Tiffany, I want some of your weather right now. Jane, I think I have some of yours. It is insane, but we are loving it. I have to tell you, my kids are having so much fun sledding and making snowmen.
22 here, so I don't have that problem.
You do not. Jane, how much snow have you guys gotten this year?
Not much. And actually, I'm looking at a backyard that is all mud right now.
Oh, wow.
So, and it was 50 degrees here. So I wish we had your snow.
Okay. All right.
I
Well,
wish we
I'm
did.
gonna send some your way because
All
this
right,
is
you do
great
that.
today, but it's gonna get old. So
Yeah.
I'm ready.
thank you
I'm
so
ready
much.
for it.
Awesome. Awesome. It's on its way. Thank you so much, Tiffany and Jane, for joining me for today. We are really honored to have you both here. We are going to be looking at some case studies together and just really illustrating the significant importance that biofeedback has, specifically on two cases that are near and dear to my heart. One is really how the tool can support people who have experienced trauma, and the other is people who've experienced bowel dysfunction. I think both cases actually really probably overlap. And so I love case studies. Thank you for coming on and agreeing to do this. So we're going to segue into that in a moment. But for those that are maybe less familiar with you than I am, I just want to mention that the two of you, what a powerhouse OT PT team, working together for 18 years, supporting countless students on how to integrate not only the foundations of what pelvic health is through your courses, but the significance of biofeedback, which I think is a really underestimated tool. So I also just want to briefly say, and I might tear up as I say this, is like I got my start in your guys' course. It was the first pelvic health course I ever took, and I was just blown away that it was a PTOT team. And I remember, Tiffany, I have so many endorphins when I talk about this and when I see you, because I remember just looking, you went out to dinner with us afterwards and you just looked at me and you said, you can do this. And I felt that in every fiber of my being. And I'll tell you, a day has not gone on since that energy and that support that the two of you gave throughout that course has fueled to the very momentum that we have today. So before we get started and roll up our sleeves, I just have to do that huge shout out because what a significant impact the two of you have on so many lives.
Well, and I had no idea that she would be the powerhouse that you became. So it's an honor to have been on the journey with you and just seeing, you know, starting out with a couple people and OTs for pelvic health. And then now the Facebook group is over 6,400 people. So you've done so much for OTs and pelvic health, and it's just exploded. And Jane is definitely more of an OT than a PT. So we've basically inducted her in the OT Association a long time ago. So I think those that meet us, we've had so much fun teaching together because our kids have grown up and we stay in each other's homes, and so it's been a great partnership, and we just are so passionate about what we teach that we just have a blast doing it.
And my start really came about with the biofeedback course, of course, that was taught by our predecessors. But that's where I really went, I can use this tool and I can make a difference in people's lives. And so it's been quite a journey, but it's been phenomenal.
Yeah. Well, I'm going to put both of your bios in the comments because I think we could take up a full 30 minutes if I spent the time going through it. Both of you have such accomplished backgrounds. So I'll definitely put that in the comments afterwards. So again, today we're going to be doing some biofeedback case studies in both bowel dysfunction and trauma. Before we do that though, Tiffany, can you just share with us a little bit about what biofeedback actually is?
Sure. I threw together some slides also
Awesome.
that hopefully we'll go over quickly because there might be some people who don't
Mhm.
really know what is biofeedback. So let me just do that. Basically, when we're looking at biofeedback, you can measure any muscle in the entire body. So some people think, well, we can only do this with pelvic floor, but it's widely used in the rehab world. And it doesn't get I think in the rehab world, everybody loves biofeedback. They talk about it, they use it. But in the pelvic health arena, people don't want to use it necessarily because they think, oh, that's replacing my hands. And they think that we're trying to do that. And that is not what biofeedback is. It's in addition to, it's a complement to your hands if you are doing that work. And it's the only tool that measures tone. We cannot measure tone with our hands. So it's a very powerful tool that can be placed in your toolbox. So it's just something to add to your skills. So what is it? It's measuring surface EMG, which is the electrical activity of the muscle. So think of an EKG measures heart activity, EMG measures muscle activity. So we can see what's happening on the computer. A lot of people don't know what's happening in their, in the pelvis. They have no idea. And so this gives them the ability to see what their muscles are actually doing. And they get that immediate knowledge, which is fantastic. So this is just showing what does the equipment look like. There are different types of equipment out there, but one that a lot of pelvic health therapists use is the Pathway from the Prometheus group. It's the MR20. We highly recommend to get at least a 2-channel system. A lot of people have 1 channel, but when we talk about coordination and bowel dysfunction, especially the 2 channels are very, very important. So this is just showing a screen that Jane and I use to assess someone in supine, sit, and stand. A lot of people are just assessing in supine. A lot of our dysfunction happens in the standing posture. And so we think it's important to assess in all 3 positions as well as use it when you're doing functional things as well. So we're going to look at a couple of the different ways to measure what do the sensors look like, what does the instrumentation look like. You can just place externally if you're working with pediatrics. This is a fantastic tool. And of course, you would only do external for pediatrics. If you have someone who does not want to insert anything, then of course you can use the external placements as well. We can't share the external placements on Facebook because we might get kicked off. So we just took away that slide. But you can measure vaginal, rectal, or external. These are some of the types of sensors that you might see out there. The top row, that is rectal, and then the bottom row are the vaginal sensors. They don't do anything necessarily they just read the activity. However, you can use these same sensors for e-stim. So that's another thing. If you have someone who has a lot of weakness or pain, you can also use the same sensors and get a special e-stim unit. These are some of the electrodes and adapters. So these are disposable on the left. You can use them around the, basically you're putting it around the external anus is where you're putting the disposable electrodes. You can use these also. I know this is very weird, but I also do facial paralysis retraining. And so I'd put these also on the face. You can use them on any muscle group in the body, but they're fantastic because they stick really well. This is just a picture. The blacked out part is a belly button, but it shows where you actually would put your abdominal electrode placement. So you're always measuring on the right-hand side so you don't pick up a cardiac artifact. And you can measure the rectus and the external obliques. It is surface EMG. So what happens is a lot of people think, oh, I can use biofeedback for TA. And you can't because the transverse abdominis, as you can see here, is much deeper. So really it picks up nicely the external oblique here and the rectus abdominis. So those are the ones that you're picking up. We're trying to measure above the level of the bladder, especially if someone has, let's say, urge incontinence and they're trying to rush to the bathroom. If they're contracting their abdominals, that's going to put more pressure into the bladder. And so we do want to measure above the level of the bladder. We're not trying to say you never use your abs when you do a pelvic floor contraction, but we do want to have less activity if we're trying to use that pelvic floor. This is another example just of showing someone contracting for 10 seconds in the supine position. The green line is the pelvic floor, the blue is the abdominals. So they are able to contract. However, over that 10-second period, they start to lose that contraction. We also look at quick flicks. So we're looking at the fast twitch muscle fibers. Does that person have coordination? So we look in the 3 positions because that's important. You can see in this last section, this is when someone's standing, it's much more challenging for them to hold that contraction. So if someone has weakness, they're having a much more difficult time maintaining that continence on the way to the bathroom or in that standing position. So this is just the assessment. We also do a lot of treatment, but this is just that quick assessment for people. So a couple case studies. Jane's going to talk about one of her patients here.
All right. Well, this is someone who after birth experienced, well, her birth was very, very traumatic. And after her birth, she found that she couldn't tolerate sexual relationships with her husband. So she didn't want anything to do with intercourse and didn't even want him coming close to her. So she went to a counselor. It was really, she couldn't understand why this was going on. And it became evident in talking to her counselor that she had suppressed a rape when she was in high school, where she had been thrown in the back of a van and a bunch of guys had attacked her there. So she had suppressed all that. And then with the birth of the child that was traumatic, it all came to the surface. So her counselor sent her to come and see me. And the beauty of this was I would see her and she would immediately get in the car and go see her counselor. So we had this great working relationship that everyone would work together to help her. So this is looking at her initial graph, trying to look at her from supine sitting and standing. And we can see that she's unable to really relax her pelvic floor. Pelvic floor is green, blue is the abdominals. And she's using a lot of her abdominals. She really didn't know how to go about making that muscle group work. And she didn't want to see it when we got into actual treatment. She took her a while to get comfortable with the whole concept. But again, with the help of her counselor, always being there for her when she got done with me, we were able to work through the details. And then on her final visit, we have a slide of her ability to do a series of quick flicks with excellent results and a series of 10-second sustained contractions. So you first see the quick flicks on the left-hand side of the screen, and then you see a series of 10-second contractions. She was able to relax her muscle. She had resumed sexual intercourse with her husband. She was happy. She was talking about having another baby. Everything worked out beautifully, and she was so happy she sent half her neighborhood and her mother to come see us. So the beauty of it was working together with more than just the therapist, but having the counselor available too. But when we talk about trauma, I think it's important to also talk about other types of trauma. One being trauma as the result of a medical appointment. Sometimes that happens, and you'll hear about it from patients that perhaps an overzealous therapist who in that therapist's mind wants to do the whole eval and get the assessment of the muscle function done and take a look at the perineal structures and pushes that aggressively on the patient to get it accomplished. And the patient really wasn't comfortable with that. And so the patient really felt violated by something like that happening, and it creates trauma. So I think sometimes as providers, we need to take a step back and say, am I pushing this for myself so I can get it done, get a note done, and get it billed? Is it in the best interest of the patient, or is it in the best interest of this patient to wait until the patient's more comfortable with me as the provider? And so you have to build that relationship. And sometimes I think we forget that. So in order to help prevent some types of trauma, it's important to really consider what's the patient goal and how can you work with your patient to achieve that.
Yeah, and I think also it's important that there are a lot of therapists that think, oh, I can't be a public health therapist unless I do internal work. And I want to tell you, yes, you can. There's a lot that you can do. If you get to the point with someone that is not improving and they do need that extra manual therapy, you can refer on, because there are many, many people who are doing it. But there's a lot of patients that appreciate that you might have that if they have had trauma. Maybe they won't do an internal assessment, or, you want to make sure that it's okay with that patient. But I do want to make sure that there are some OTs out there that are worried about that. At our course, we don't do any internal. I feel like sometimes the very initial courses that when people take, like the Herman and Wallace course, and it's like, it's very unnerving for a lot of people. So we decided for our course that everybody's fully clothed. You put your own sensors in so that you can be really comfortable and be able to learn and not be so worried. I know when I went to those courses, I don't think I learned anything because I was so embarrassed and terrified. And so that's just my personal experience. But I think for
super quick,
yeah,
Tiffany, what you just
yeah.
said about your experience and how you were terrified. First of all, I can totally relate. And second of all, that's exactly what our clients are experiencing.
Exactly.
So imagine, right, that same feeling. You could have the best manual skills, the best movement sequences in the world, the best therapeutic touch. If they're not feeling safe and their nervous system isn't regulated, none of that is able, the client is just not able to absorb that, any of that beautiful education that you're giving them.
Sometimes it will
agree.
take 3 or 4 visits before someone will say, okay, I'm ready. Because they have to
Mhm.
develop that trust and be able to relax in that treatment room and not have that fear of what's she going to do. So I typically, when I go into a room, will say, I will give you some suggestions of things I might do, but if there's something out of that list that you don't want me to do, I won't. And for someone that I know has had some abuse, I'll always say, what would you like me to do today? What are you willing to participate in? And let them
And how
run
can,
the treatment.
right. And how can we look at a muscle without actually touching the muscle? And that's why this tool is so wonderful, because if you aren't able to touch, then we can also see what is happening with that muscle. And then they can actually see also without having to feel like they're embarrassed or upset or traumatized. And so I think that's very important. So that's why we also love this tool. I'm going to jump in. We're going to come back to one more patient after this one, but I will tell you that out of any of the certifications that I have, the only one that has brought me business is the biofeedback one, because I get at least 5 referrals a week from colorectal surgeons. There's so much research that talks about how great biofeedback is for all of our bowel cases. So I think it's important to, if you don't have referrals from GI docs and colorectal surgeons, this is one thing you can go out and say, hey, I offer biofeedback, and you will get busy. I promise. So this was a case study of a 39-year-old female. She had a lot going on. IBS, DR, asthma, all the prolapses. She was also having fecal incontinence, hemorrhoids, bowel urgency, abdominal pain. She had a lot going on. Difficulty with emptying, straining, and type 1 to 3 stool. So she also had a lot of the different types of therapies, like, okay, we're going to do education on proper bowel habits, posture, positioning. She wasn't having the improvement. So this is someone that had seen somebody else. They were referred over to biofeedback so that she could figure out, how do I actually empty? And I do see a lot of patients who have outlet obstruction where their muscle is not releasing and relaxing, so they're not able to empty fully. And it's hard to, most people have no idea that they have this in coordination. They just, when they see it, they're like, oh, I didn't even know I was doing that. So it's very powerful for the brain to be able to see, what do we do to fix this? So what's happening here in this screen is, when we ask someone in a sitting posture, because we're not having them doing this lying down, it's another reason why people who've been trained in biofeedback just in supine, you can't really teach very well how to have a proper bowel movement. So we do want the patient to be in sitting. When we ask them to bear down or act as if they're having a bowel movement, what you're seeing here is green is pelvic floor. Their pelvic floor is tightening rather than relaxing. And so you really don't want to see green going up in this case. You want to see the blue going up. We want to have more of the abdominals creating that intra-abdominal pressure, and we want the pelvic floor to open and relax. So we're seeing the opposite here. So when I do this with a client, when I ask them to do the bear down, this is what you don't want to see, the incoordination, but I see it several times a week in the clinic. So we have to work on, how do we get them to reverse this? And so one thing is they have to see it. So that's why we do this. This is the same client after 2 sessions. And what's happening here now is, whenever she does do that bearing down, this is what we want to see. The abdominals have the increased activity. The pelvic floor is relaxed. And so we did several things. You can do breath work. You can do something called bowel movement breathing, where the belly, belly big, belly hard. People might have heard of that. Hissing like a snake. There's so many different types of ways that you can work on it, but you have to get this pattern corrected for someone to have full relaxation of the muscles, to have an emptying. So this is one of the biggest reasons why I get referrals from the colorectal surgeons, is they want this fixed before they do a surgery. That's important. And so that's why I love to add this, is just that people don't think about getting those type of referrals, and they're such a fun population to work with. So we spend a lot of time at our course talking about bowel dysfunction. Also use a lot of Lindsay's great slides from her course, OT Elevate, which is a fantastic course as well. But we spent about 4 hours going over all of the bowel dysfunction. What are the medical diagnostic tests that you would see? What is a defecography? What are some of those really cool tests that they use? Also talk a little bit about manometry. So there's a lot involved. And then Jane has a really cool, this, just so you can see how this relates, how you want the abdominals to be working on this little next slide here.
So this was an interesting case because it was a 75-year-old woman who has a cardiac arrhythmia that she's challenged to get under control. They've tried lots of medications for her, and they're not all really working up to speed for her. So she's got a lot going on with her cardiac condition, and she's been super constipated. And every time she gets really constipated, her arrhythmia gets worse. And she noticed that because she was going to the ER and having to get cleaned out in terms of her bowel function. And every time that she had a clean out, she felt much better in terms of her cardiac status. She wasn't having all the arrhythmias. So she spoke to her cardiologist, and the cardiologist said, I don't know, go talk to your GI. And the GI specialist said, I don't know, go talk to your cardiologist. And so she really wasn't getting anywhere with that. So I knew her. So she said, can I just talk to you about it? So we did. And I asked her if she knew anything about a vasovagal response. And she had heard of it, but didn't know much. But it makes a lot of sense that when she was trying to bear down to move her bowels, she was actually increasing the tension, which was playing havoc with her cardiac status. So we talked a lot about the lack of coordination of her pelvic floor, like Tiffany was just talking about. And as she gave me her symptoms of other things in terms of her bowel habits, and we talked about this, she's like, I think that's what's going on. So I hooked her up to the surface electrodes, and this is what we saw. So the green is her pelvic floor. We're working on teaching her. So this is just the teaching session right here. And as she's practicing, she had higher, like you would have seen in Tiffany's graph, she had higher abdominals initially, but now what you're seeing is she can get her abdominals higher, excuse me, she had higher pelvic floor. Now what she's getting is higher abdominals, and she's minimizing her pelvic floor. And hopefully the next time I see her, it will even be better than what you see here. But she's trying to get it all to relax. The reason you don't see it in pretty colors is I was working on a different graphic when we were working together, and this is how it's presented after the session. The important thing is ask your patients about quality of life. So this woman's quality of life clearly was not up to speed, and normally she would go away for the whole winter and head south to someplace really sunny, but she didn't dare go because of all of this happening. Well, she texted last week to say, I'm gone, bye-bye. I feel so much better and so much more confident in that one session. Just learning how to be able to start to coordinate those muscles. So this is what makes it so powerful.
That is
Love
so
It's a
it.
great tool.
Mm-hmm.
Tiffany, I'm sorry. I think I interrupted you.
Oh, no. I was just going to say, just so we have time for questions too, but
Yeah.
what's interesting about our course is we probably do about 50 different case studies because we've had over 55 years of experience combined of seeing so many thousands of patients. So we do talk a lot about, well, what would you do? And the cool thing is we have OTs, PTs, nurses. We have sometimes we'll have a colorectal surgeon there. Sometimes we'll have a urogynecologist. So it's this round table of different types of professions, kind of like, this is what I would do, and this is what I would do. And so we learn a lot from each other. So it's a really fun, we like a very small course. We don't usually have more than 16 is what we really like, just so there's more quality, not quantity. It's not like you're sitting in a room of 50 people trying to learn. So we enjoy that. If you are interested in getting board certified, you don't have to get board certified to come to the course. It's a great foundational course. But if you are interested, then you can, these are the types up here: RN, NP, PA, MD, OT, PT. Also, CODAs and PTAs can get certified. So we do offer 28 hours of didactic education. What's great is there's mentoring. So we get to work together, talking about your patients. And it's 12 contact hours, just 12 Zoom meetings. You don't have to go anywhere. You can just be talking from your clinic. So we love doing that. The other nice thing is the exam is not that expensive. You know, if you look at some of the other exams that are thousands of dollars, then this is one that's only one time. You would take it one time. It's $300. And then you'd never have to take it again, which is nice. And then you get recertified every 4 years to maintain your certification. Pretty much you can use any of your pelvic health, you know, any of the courses that you take, even for Lindsay's courses or the summit, that all would also count towards those hours, which is great. This is just some of our company is Biofeedback Training and Incontinence Solutions. Twice a year, springtime in Texas and late summer or fall in Vermont, because those are our hometowns. We love to show, hey, this is what we do in Texas. Let me introduce you to barbecue and Mexican food. And then in Vermont, it's so gorgeous.
Eat healthy food.
Yeah, we do healthy at Jane's and we do, you know, kind of the unhealthy at mine.
Occupational balance. That's what it's all about.
Exactly. We do teach for Herman and Wallace twice a year. It's just a 1-day lab, but you have to have the equipment. Our bigger course, we have everything for you. We have all the equipment. CMT Medical comes, they come with all of their dilators and equipment. And so you get to see everything, pelvic health, which is really fun. We have a great time. It's just a lot of fun. We do have a pelvic floor biofeedback Facebook group, and it's growing. It's not growing as much as Lindsay's, but it's growing. So we would love for you to join, just so, you know, you can hear more about case studies and ask any questions. And I'm hoping more OTs. This is such an OT tool. And I will tell you, there's about 80 PTs in the country that are board certified. There's only about 30 OTs, and I want to flip that. I think this is a great tool for OTs to be using. And it's adding, it's not taking away from any of the other things that you do. It's adding to that toolbox. And I will tell you, every single patient that I've ever done biofeedback with says, this is my most favorite thing I've ever done. And they ask to do it again. They want to do it. They want to learn how to control their own bodies. So I think that that's really important, is we want to offer something that our patients can have their own control of their bodies. I think that's very important.
You know, I want to
too.
just come back, if I can, for a second and talk about mentoring, because a lot of times when someone attends the course, they'll say, I don't know, I really don't know anything. Should I mentor? And that's an opportunity to learn how to walk and then run. I mean, it gives us such a great opportunity to take them and train them through the challenges of what their various patients may present when they come for treatment. And it reminds them, yes, do your manual work, add this as a piece of the treatment, add something else. It gives them that whole equation to help them become really, really excellent clinicians in terms of pelvic floor care. And they just grow so much through that process.
Well, I would love to invite anybody joining us live for any questions about any aspect of this awesome case study presentation that Jane and Tiffany have given us. And while we're waiting to see what questions come in, Tiffany and Jane, tell us, I think it's happening in Texas next in April. Can you give us the dates for that?
So it's April 11th through the 13th in San Marcos, Texas, just 30 minutes south of Austin. So we're right in between Austin and San Antonio. So a lot of times the attendees will go down to the Riverwalk and they'll go up to Austin to 6th Street. So we're right in the middle there. And it's really pretty, April in Texas. We are going to be doing in Vermont. We've got August 22nd through the 24th. It is 1 week after our OTs and Pelvic Health Summit. So, but I'm doing it, so you can do it with me if you want to go 2 weeks in a row to do something fun. And another thing is, a lot of people ask, do I have to have experience? We actually love newbies that know absolutely nothing. That's what I did when I took the course. I knew nothing. And even someone who's been out for 20 years, they come to our course and they've been to every course ever through Herman and Wallace or even through APTA, and they'll say, oh my gosh, I learned so much. This is such a great course. So you can be brand spanking new, or you can have a lot of experience and you'll find that you'll learn so much.
I love that. I put those April dates into the comments, Tiffany, but if you don't mind coming in and just giving the link for where people can read more when you have a chance, and maybe even link to those fall dates in Vermont.
I'll put in the website too, so that'll
Awesome.
be good.
Perfect.
Well, I cannot thank you both enough for coming in and sharing your very clear passion for serving pelvic health clients. Just decades upon decades of wisdom and support that you have given all of us. So thank you for sharing this with us. I hope you both have a beautiful weekend, and just excited to hear about all the OTs that join you guys in April.
Thank you for
And have
having us.
fun making snow angels.
Yeah.
Oh, we will for probably many weeks to come, Jane. So like I said, expect some snow to be coming your way.
All right, I'll look for it.
All right. Take
Thank
care,
you.
everyone. Great to see you
Bye-bye.
both.